Chapter 11, the Medical Documentation and the Electronic Health Record. Chapter 11, Objectives, the Medical Documentation and the Healthcare Record. Number 1 is to be able to identify the most common documents found in the health record. 2, discuss health record systems and list the advantages and disadvantages of an electronic health record system. 3, define the various titles of physicians as they relate to the health record documentation. 4, explain the reasons that legible documentation is required. And 5, describe common billing errors found in the health records and define medical necessity. Number 6, discuss various billing patterns that could cause possible audits. 7, define common terminology related to medical, diagnostic, and surgical services. 8, abstract information from the health record to complete a life or health insurance application. 9, describe the difference between prospective and retrospective review of records. And 10, respond appropriately to the subpoena of a witness and records. 11, identify principles for retention of health records. 12, formulate a procedure for termination of a case. And 13, discuss in-depth documentation requirements for evaluation and management services, including documentation guidelines for medical services, as well as the documentation of history, examinations, and medical decision-making. The documentation process. Anything in the patient record is considered documentation. Documentation is a chronologic detailed recording of pertinent facts and observations about a patient's health as seen in the chart notes and medical reports. The health record is a written or graphic information documenting facts and events during the rendering of patient care. These forms may be kept on paper or microfilm or electronically depending on the system used in the medical office. A hospital record would also include an attending physician's order, date of admission, hospital stay dates, discharge dates, and discharge summary. Also, some of the most common medical documents would be the patient registration, which is the demographic information, such as your name, address, date of birth, those kind of things. The medication record, history and physical examination notes or report, progress or chart notes, consultation reports, imaging and x-ray reports, laboratory reports, immunization records, consent and authorization forms, the operative report, and pathology report. Health record systems. The POR, or the problem-oriented record, is a system that allows a physician to quickly locate information and compare evaluations. The SOR, the source-oriented record, is a system that organizes documents into sections, not by data. The EHR, the electronic health record, is a collection of medical information about the past, present, and future of a patient that resides in a centralized electronic system. This system receives, stores, transmits, retrieves, and links data from many different information systems. The EMR is an individual physician's personal medical record on a patient. Everything contained in the EMR is contained in the EHR. Electronic health records. Computer systems can make data from medical records available for the other purposes to help develop protocols and critical pathways for disease management. An EHR system holds information in a centralized location, giving access to all patient data quickly. The disadvantages of EHR include startup costs, usability, and learning curves for the employees. All confidentiality and security issues are viable concerns. Some of the advantages of EHR is less physical space required, automatic data capture, available data for other purposes, easier authentications, automatic insurance verification, automated computer-assisted coding, batch transmittal of insurance claims, and complete online management. Incentive programs for the adoption of electronic health records. The PQRS, the Physician Quality Reporting System, was one of the initial incentive programs resulting from the Tax Relief and Healthcare Act of 2006. The program started in 2011. Beginning in 2015, eligible providers who do not report PQRS measures satisfactorily will be subject to payment adjustments equal to 1.5% of their Medicare physician's fee schedule. The e-prescribing incentive program started in 2011 and ended in January of 2014. Physicians who do not successfully e-prescribe will be penalized at the rate of 2% through 2014 and 2015. Under the Medicare Incentive Program, eligible providers that begin participation in this program prior to 2013 had the opportunity to earn incentive payments for up to 5 years. Under the Medicaid Incentive Program, the EPs have the opportunity to earn incentive programs for up to 6 years. Meaningful use. Meaningful use involves demonstrating that the healthcare organization has the capabilities and process in place so that the provider is actively using certified EHR technology to improve quality of care, patient safety, and efficiencies in healthcare, as well as reduce health disparities. Engage patients and families in management of their care, improve care coordination and the general public health, and maintain privacy and security of patient health information. The different stages are as followed. Stage 1 was 2011 to 2013. That focus was on data capture and sharing. Stage 2 was 2014 to 2015, focuses on advanced clinical processes. And then 2016 and above is a focus on improved outcomes. Documenters. So the types of physicians that do documentation are the attending physicians, consulting physician, non-physician practitioner, the NPPs, such as your nurse practitioners or your physician's assistants, the ordering physician, primary care physician, your PCP, referring physician, the resident physician, teaching physician, and treating or performing physician. Legible documentation. Now, why does documentation have to be legible? It's to prevent problems with insurance claims and to comply with laws and guidelines related to the medical documentation. Some of it is also the avoidance of denied and delayed payments by insurance carriers investigating the medical necessity of services, enforcement of medical record keeping rules by insurance carriers requiring accurate documentation that supports procedures and diagnostic codes, the subpoena of medical records by state investigators or the court for review, defense of a professional liability claim, and execution of the physician's written instructions by a patient caregiver. Common documentation errors. When healthcare providers put patient care first, documentation is a process that follows and is oftentimes dashed off too quickly. Some medication lists are not updated. Incorrect dosages of prescription medications are documented. Duplicate prescriptions are documented for brand and generic medications. Over-the-counter medications that the patient is taking are not documented. Allergies are not documented. Lab information is missing or not updated. And inaccuracies in diagnosis are made. Medical necessity. Payment may be delayed, downcoded, or denied if the medical necessity of a treatment is questioned. Medical necessity is a criterion used by insurance companies as well as Medicare. Medical treatments must be done in accordance with the standards of good medical practice and the proper level of care. Insurers differ on the definition of medical necessity. Legalities of health record billing patterns. Medicare fiscal intermediaries have walk-in rights that they may evoke to conduct documentation reviews, audits, and evaluations. Falsifying information of any type on a medical record would be considered fraud. Therefore, billing for tests not in the record or changing dates of service on the claim would be considered fraud. Some billing patterns causing possible audits would be billing intentionally for unnecessary services, billing incorrectly for services of a physician extenders, billing for diagnostic tests without a separate report in the medical record, changing dates of service on insurance claims to comply with the policy coverage dates, and waiving copayments or deductibles or allowing other illegal discounts. Ordering excessive diagnostic tests, using two different provider names to bill the same service for the same patient, misusing provider identification numbers resulting in incorrect billing, using improper modifiers for financial gain, and failing to return overpayments made by the Medicare program. All of these patterns are considered fraud or abuse. Documentation terminology. Evaluation and management, E&M terminology. Reimbursement for a consultation is significantly more than for an equivalent office visit. Some of the terminology will be new versus established patient, consultations, referrals, concurrent care, continuity of care, critical care, emergency care, and counseling. Now, what is concurrent care? That are provisions of similar services, such as hospital visits to the same patient by more than one physician on the same day. Continuity of care is when a physician sees a patient who has received treatment for a condition as referred to by the previous doctor for treatment of the same condition. Critical care usually takes place in the emergency department or a critical care unit of a hospital. Diagnostic terminology and abbreviations. The American Hospital Association's, AHA's, official policy is that abbreviations should be totally eliminated from more of the vital sections of the health record. Many physicians are not aware of this policy, and they may continue to use abbreviations throughout the documentation. Eponyms are the name of a disease, the anatomic structure, operation, or procedure, usually derived from the name of a place where it first occurred or a person who discovered or first described it. Acute and chronic is that an acute is a condition that runs a short but relatively severe course, and chronic is a condition persisting over a long period of time. Documentation should be as specific as possible to assure which one of these would be. Surgical terminology. Preoperative is the period before a surgical procedure, and postoperative is the period after the surgical procedure. Surgical procedures of interventory system are listed as simple, intermediate, or complex. In a surgical report, undermining means to cut in a horizontal fashion. Take down means to take apart. What our lysis of adhesions means is that the destruction of scar tissue. And codes can be different depending on the position or the approach documented in the surgical report. Abstracting from medical records. Abstraction from medical records may be required for 3 situations. 1, to complete insurance claim forms. 2, when sending a letter to justify a health insurance claim form after professional services are rendered, and when a patient applies for life, mortgage, or health insurance. In some situations, it is preferable to submit a narrative report dictated by the physician instead of completing the form. It may also be necessary to attach a copy of an operative, pathology, laboratory, or radiology report, an electrocardiogram, or an EKG tracing. Internal reviews. Internal reviews may help prevent external audits and may catch errors before the billing cycle is complete. This will save the practice time, money, and possible penalties in the long run. A prospective review in stage 1 is to verify that completed encounter forms match patients seen according to the appointment schedule and have been posted on the day sheet. Stage 2 is to verify that all procedures or services and diagnoses listed on the encounter form match data on the insurance claim form. Retrospective review is to determine whether there is a lack of documentation. The subpoena process. Subpoena means under penalty. It also refers to the writ that commands a witness to appear at a trial or other proceedings and give in testimonies. Subpoena ducis tecum literally means in his possession. This is a subpoena that requires the appearance of a witness with his or her records. If needed for a trial, records must be kept secure. They should be mailed via certified mail or other secure method with a return receipt. Always comply fully with the subpoena or any instructions during the court proceedings. And never accept a subpoena or give records without the physician's prior authorization. Prevention of legal problems. An insurance billing specialist must be aware of legal issues in the medical practice and must follow guidelines to limit the likelihood of a lawsuit or external audit. This will help by keeping patient information confidential. Report all physician activity that is illegal or unethical. Be aware of any hazards that may cause injury. Do not discuss other physicians with patients. And take the time to explain fees to the patients. Be sure documentation corresponds with insurance billing. Be aware of all changes in insurance program guidelines. Always obtain written consent for records release. Obtain physician authorization before turning an account over for collections. And always act in a courteous and professional manner. Documentation guidelines for evaluation and management services. The documentation of each patient encounter should include or provide reference to the following: the chief complaint, relevant history, examination, findings, prior diagnostic test results, assessment, clinical impression or diagnosis, plan of care, and date of legible identities of the healthcare professional. The audit point system. A point system is used while reviewing a patient's health record during the performance of an audit. It is possible that the auditor may shift the points from the history of present illness, the HPI, to those required for the review of the body's systems. HMOs, PPOs, and all private carriers have the right to claim refunds in the event of an accidental or intentional miscoding. And remember, if it was not documented, then it was never performed. Documentation of history. The extent of the history depends on the clinical judgment and the nature of the presenting problem. In your documentation history, you'll have your chief complaint, which is the CC, history of present illness, the HPI, review of systems, the ROS, and we're talking about your body systems, such as respiratory, cardiovascular, etc. Your past, family, or social histories, the PFSH. Documentation of examination. The documentation would include the physical examination, the organ systems and body areas, the types of physical examination such as problem-focused, expanded problem-focused, detailed, or comprehensive. Documentation of medical decision-making. Medical decision-making, the MDM, is a healthcare management process done after performing a history and physical exam on a patient that results in a plan of treatment based on establishing one or more diagnoses and or selecting a management or treatment option. Morbidity versus mortality. Now, morbidity is a disease condition or state, whereas mortality has to do with the number of deaths that occur in a given time or place. To conclude the internal review of the patient's health record, a level must be determined by the healthcare provider from one of 4 types of MDM, either being straightforward, low complexity, moderate complexity, and high complexity. And this concludes the lecture of Chapter 11, Medical Documentation and the Electronic Health Record.